Okay, it's looked like asthma. This patient who was previously intubated due to a myasthenic crisis now has intermittent episodes of cough and dyspnea. Several features of his presentation suggest intermittent asthma. Important thermomechanical asthma triggers include exercise, jogging, and extremes of temperature and humidity, cold, dry air, hot, humid air. The mechanism likely involves local changes in the blood flow and neural input that stimulate the inflammatory cell, mast cell eosinophil activation and mediate release by leukocyte in the bronchial valve. Key inflammatory mediators include histamine and leukotriene, which exert paracrine effects on adjacent cell in the airway wall. Smooth muscle cell depolarize, leading to bronchoconstriction, and goblet cell are activated, causing mucus hypersecretion. So, smooth muscle depolarization can cause bronchoconstriction, and goblet cells are activated, which promotes mucus hypersecretion. So, these response account for the cardinal symptoms of asthma attack, episodic dyspnea, cough, wheezing due to airway inflammation and obstruction. Bronchial edema and hypersecretion may lead to expectoration, non-purulent whitish mucus. Mobilization of this secretion relieves airway plugging, resulting in partial symptom relief as seen in this patient. In patients with intermittent asthma, lung sounds may be normal during calm tidal breathing in intermittent asthma, although wheezing can sometimes elicit by forceful exhalation, reflecting residual airway inflammation and spasticity. Okay, next. Okay, look, chest X-ray reveals displaced fracture of posterior ninth and 10th rib. So ninth and 10th rib like intra-abdominal viscera, intra-abdominal things are present like liver on the right, spleen on the left, kidney posterior ribs 11 to 12. So they are, if it is 3 to 6 then cardiovascular, if it is 9 to 12 it is intra-abdominal, if any level pulmonary. This patient fall resulting in displaced left lower rib fracture causing injuries to the spleen, In the setting of tachycardia, is concerning for early hemorrhagic shock and her uh, shoulder pain with normal neuromuscular examination is concerning. For referred pain from the diaphragm is concerning from the referred pain from of left diaphragm because the intimate association between the diaphragm and the splenic capsule, a content splenic bleed can present with referred left shoulder pain. Fracture and 9 to 12 can injure intra-abdominal organ. However, hollow viscous, which may be subdiaphragmatic here on upright X-ray, solid organ, liver, spleen, kidney. Injuries are typically not visible on plain abdominal X-ray. Okay, okay. And as my exacerbation is defined as an acute worsening symptoms, cough, wheezing, dyspnea accompanied by a significant decline in the respiratory flow rate. Acute exacerbation occur when sensitized bronchiole exposed to trigger respiratory tract infection, allergen causing muscle degranulation. In the immediate phase, minutes to hours, and asthma exacerbation release of preformed mediated histamine leukotriene causes immediate bronchoconstriction, airway edema, mucus production. Initial treatment of acute asthma exacerbation focuses on relaxing bronchoconstriction with short-acting beta agonist albuterol, a short-acting muscarinic antagonist, and IV intravenous magnesium. Hours after immediate response, a late phase reaction occurs, characterized by pro-inflammatory gene expression de novo, T helper 2 cytokines, and further recruitment of the leukocyte, all contributing to ongoing bronchospasm and inflammation. Systemic glucocorticoid, oral prednisolone, and dexamethasone reduce late phase inflammation. Prednisolone 40 to 60 milligram for 5 days to prevent relapse and decrease the need of hospitalization. Okay, look at this box. Very higher. Uncomplicated paraneumonia diffusion. In uncomplicated pH is 7.2 decrease or normal glucose LDH is more than zero point 0.6. In complicated pH is less than 7.2. pH is less than 7.2. Glucose is low. LDH is more than zero point 0.6. And in PIMA, LDH is low. Glucose is low. pH is less than 7.20. Glucose is low. LDH is more than zero point 0.6. Pleural fluid and gram stain. In uncomplicated, it is negative, complicated, positive or negative, and in PIMA, positive. This patient with fever, shortness of breath. This patient with fever, shortness of breath, evidence of pneumonia, right lower lung opacity, and a pleural effusion, right lower lung opacity, and a pleural effusion on chest X-ray has parapneumonic effusion. Parapneumonic effusions are exudative effusion that can develop as a complication of pneumonia due to inflammation and infection. Due to inflammation and infection of the adjacent lung infection resulting in accumulation of the pleural space. As the inflammation and the infection spread through the pleural space, pneumonia effusion can present as a spectrum of disease. Patient usually develop an uncomplicated simple pneumonia effusion as the inflammatory fluid enters the pleural space. As the inflammatory fluid enters the pleural space, because the fluid is sterile, pH more than 7.2, glucose is normal to slightly decreased, LDH is normal. In complicated pneumonia effusion, when bacteria or microorganisms begin to invade the pleural space, therefore in patients pH is 7.2, low glucose, and LDH is more than zero point 0.6. Okay, a complicated pneumonia effusion becomes the empyema when the fluid is grossly purulent, pH less than 7.2, low glucose, neutrophil predominant leukocyte more than 50,000, and significantly elevated LDH. So neutrophil predominant leukocytes and significantly elevated LDH looks like empyema. Empyema brought with an antibiotic and drainage. Okay, okay. Look at this question. There is decreased urine sodium. The patient recent history of diarrhea and poor appetite as well as flat neck pain, recent history of diarrhea, poor appetite, as well as flat neck pain on physical examination strongly suggest hypovolemia, depletion of water and salt, and that's making susceptible to orthostatic hypotension and orthostatic syndrome in the setting of hypovolemia. Hypovolemia decreased renal perfusion, so it increases RAS. So aldosterone stimulate aggressive sodium reabsorption. Aldosterone aggressive sodium reabsorption in the collecting tubule of the kidney in an effort to sustain blood volume. Consequently, most patients with hypovolemia, unless taking diuretics or experiencing significant renal impairment, has decreased urinary sodium. FeNA, the fraction of excretion of sodium ratio of renal sodium clearance, is typically less than 1%. Why not decrease serum sodium? Hypovolemia triggers non-osmotic release of ADH. ADH can lead to decreased serum sodium concentration, hypovolemia, hyponatremia. However, many patients with volume depletion have normal serum sodium concentration, and some demonstrate hyponatremia. Water deficiency is more than the salt deficiency. So hypovolemia means the common cause of orthostatic hypotension, orthostatic form, due to decreased renal perfusion, activation of the RAS, which will decrease urine sodium and is present in patient with hypovolemia. Okay, this patient has COPD and acute shortness of breath, unilateral decreased breath sound. Unilateral decreased breath sound has a secondary spontaneous. Unilateral decreased breath sound likely has a secondary spontaneous pneumothorax. Secondary spontaneous pneumothorax occur in patients with known lung disease, COPD, cystic fibrosis. Other common manifestations include chest pain, hyperresonance to percussion. Cigarette smoking markedly increases. Cigarette smoking markedly increases the risk of pneumothorax. Chronic destruction Chronic destruction of alveolar sacs leads to formation of large alveolar bleb. Chronic destruction of the alveolar sac leads to formation of large alveolar blebs. Okay, this patient with COPD and acute shortness of breath, hypoxia, and unilaterally decreased breath sound likely as secondary spontaneous pneumothorax. SSP occurs in patients with known lung disease, COPD, cystic fibrosis. Other common manifestations include chest pain, hyperresonance on percussion. Cigarette smoking markedly increases the risk of pneumothorax. Chronic destruction of alveolar sacs leads to formation of large alveolar bleb, which can eventually rupture and leak into the pleural space. Di- Diagnosis of the pneumothorax is made by chest X-ray, which demonstrate visceral pleura beyond which no pulmonary markings are apparent. Tracheal deviation. Okay. Next. So it looks like a spontaneous pneumothorax. This patient's presentation respiratory distress, unilateral decreased breath sound with increased brightness or transillumination. Respiratory distress, unilaterally decreased breath sound with increased brightness. Transillumination is consistent with pneumothorax premature infant, particularly those with RDS. Particularly those with RDS are particularly increased risk. Particularly increased risk because insufficient surfactant makes the alveoli less expandable and more prone to rupture. Mechanical ventilation, nasal positive air pressure increase the pneumothorax. A typical presentation is acute onset tachypnea, grounding, cyanosis, decreased breath sound on the affected side. Patient with tension pneumothorax in which high intrapleural pressure decreases venous return. Subsequent cardiac output exhibit severe distress with hypertension and hypoxemia. Accumulation of intrapleural air may cause displacement of the heart to the right as in these cases. Okay. Okay, so chemical pneumonitis. Inhalation of gastric acid leads to direct chemical injury of the bronchial and alveolar epithelial cell, and it is different from aspiration pneumonia where there is fever, cough with putrid sputum, and aspiration pneumonia usually happen a few days to weeks. Okay, next. Okay, look at here. This patient with extensive mucosal candidiasis, white plaques that suggest and immunosuppressed state AIDS, now has cough, dyspnea, fever, hypoxemia, which together are highly suspicious for pneumonia. Immunosuppressed patients are susceptible for pneumonia. Due to typical organism, streptococcus pneumonia as well as opportunistic organism, pneumocystis jirovecii. In pneumonia, the alveoli becomes filled with inflammatory exudate, leading to hypoxemia due to marked impairment of alveolar ventilation in the affected portion of the lung. The result, the result is right to left intrapulmonary shunting. The result is right to left intrapulmonary shunting and an extreme form of ventilation perfusion mismatch, in which there is perfusion of lung tissue in the absence of alveolar ventilation. Depending on how much of the lungs are affected by intrapulmonary shunting, the resulting hypoxemia may or may not have correct with increased fraction of inspired oxygen, increased FiO2. Severe pneumocystis jirovecii pneumonia in particular may cause widespread intrapulmonary shunting with hypoxemia that is difficult to correct with supplemental oxygen. So in here, pneumonia causes hypoxemia, right to left intrapulmonary shunting, an extreme form of ventilation perfusion mismatch, an extreme form of ventilation perfusion mismatch. Depending on how much of the lungs are affected by intrapulmonary shunting, the resulting hypoxemia may be difficult to correct and increase fraction of inspired oxygen. Okay, looks like epiglottitis. On physical examination, the patient appears anxious, sitting up, leaning forward, drooling, inspiratory stridor, and suppressed tonal retraction. Looks like this is the tripod position. Trunk leaning forward, mouth open, neck and chin extended. So airflow, swelling, epiglottitis, obstructs airway, esophagus airway. So epiglottitis. In initial management of epiglottitis is to secure the airway due to the risk of complete airway obstruction in epiglottitis. The patient does should be kept calm, and aggravating intervention, that is detailed oropharyngeal examination, should be minimized because agitation may cause laryngospasm in children with respiratory distress such as this patient with stridor, retraction, cyanosis, and endotracheal intubation should be performed in a controlled setting. Emergency department operating room with trained personnel, anesthesiologist is available. Due to risk of obstruction, patient may require surgical airway tracheotomy and needle cricothyrotomy if attempts at intubation fail. Increasing shortness of breath, right-sided pleuritic chest pain for 10 over 10 days. He visited An urgent care center 5 days ago diagnosed with pneumonia. The patient received an unknown antibiotic. Okay, not help. Cardiopulmonary examination show dullness to percussion over the lower part of the right lung. Dullness to percussion over the lower part of the right lung and normal heart sound. There is no peripheral edema. Chest imaging show a large loculated right-sided pleural effusion. Large loculated. So looks like complicated pleural effusion. Low glucose, low pH, and high protein. So it's a complicated pneumonia effusion or empyema. Low glucose less than 60, low pH less than 7.2. LDH is higher, WBC count is more than 50,000. Complicated. Uh, so in pleural fluid characteristic, pleural fluid cytology, cell count, WBC count, pleural fluid pH, and glucose and protein. These are the things seen on the pleural fluid characteristics, and pleural fluid gram stain and culture is a negative, and treatment is antibiotic for uncomplicated. For complicated pleural fluid characteristics, pH 7.2, glucose less than 460, WBC count more than 50,000, and LD is more than 1,000 positive. Gram stain and culture, and antibiotics and drainage. Okay, this patient with asthma with dyspnea, cough, accessory muscle loose, difficulty speaking, acute severe asthma exacerbation. The initial physiologic response to acute pulmonary insult, such as asthma exacerbation, is an increase in respiratory drive and resultant hyperventilation. These response may be caused by a combination of hypoxemia, anxiety. These response may be caused by combination of hypoxemia, anxiety due to sensation of dyspnea, and signals from thoracic neural receptor influenced by change in the lung volume, presence of inflammatory chemicals, prostaglandin histamine hyperventilation results in decrease in PaCO2, and primary respiratory alkalosis decreased in PaCO2, which is typical presentation in asthma exacerbation. This patient ABG result demonstrate as normally think like that in asthma there is hyperventilation, so PaCO2 would be low, so there is respiratory alkalosis. But if these patients ABG demonstrate essentially normal pH and normal PCO2, getting which in this setting ongoing increased work of breathing and indicates inability to maintain adequate ventilation, the inability to meet the demands of increased respiratory drive, the inability to meet the demand of increased respiratory drive is caused by respiratory muscle fatigue or severe air trapping, suggest impending respiratory collapse. Severe air trapping and suggest impending respiratory collapse. So patients with asthma exacerbation usually have respiratory alkalosis with low PaCO2. Respiratory alkalosis with low PaCO2 due to hyperventilation in normal or elevated PaCO2 is an alarming and extremely important finding suggesting of respiratory failure. So how do you understand uh, a patient with asthma exacerbation is on respiratory failure? If PaCO2 is normal or increased, then we will understand that he is on respiratory failure, because in asthma what happens? In asthma there is hyperventilation, so PaCO2 would be low, but in here in these ABG with asthma exacerbation his PaCO2 is normal, so looks like he is on failure. This is solitary pulmonary nodule. Factors increasing malignant probability is large size more than 2 centimeter. This is large size, or recommend surgical excision. Large size, advanced patient age, female sex, large size, advanced female age, female sex, active or previous smoking, personal, family or personal history of lung cancer, upper lobe location, speculated radiographic appearance. A solitary pulmonary nodule is defined by the following features: rounded opacity less than 3 centimeters in diameter. More than 3 centimeters is considered as mass rather than a nodule. Surrounded by pulmonary parenchyma, no associated lymph node enlargement. So, a solitary pulmonary nodule is defined round opacity less than 3 centimeters in diameter, and if it is more than 3 centimeters, considered as mass rather than a nodule. Surrounded by pulmonary parenchyma, no associated lymph node enlarged. The size of the SPN strongly correlates to the chance of being malignant. If the nodules is less than 0.6 centimeter are unlikely to be malignant and generally do not require follow-up. Nodules more than 0.8 centimeter require additional management, biopsy, surgical excision, or surveillance repeat CT. In addition to size, factors that influence the probability of an SPN being malignant include patient's age, sex, smoking history, family history, location of the nodule in the lung, radiographic appearance of the nodule, regular versus irregular borders, nodules more than 0.8 centimeter that are intermediate or high probability of malignancy, more than 5% risk. Based on these factors, require tissue diagnosis with biopsy or surgical excision. Therefore, these relatively large 0.8 centimeter SPN with irregular borders in a 65-year-old patient with a significant smoking history has a high malignant probability and should be biopsied, should be biopsied and or surgically excised. For patient with whom need true diagnosis is unclear. Okay, so we have to remember that solitary nodule less than 0.6 centimeter are unlikely to be malignant, but solitary nodule more than 0.8 centimeter require additional management, surveillance. Nodules that are intermediate or high probability of malignancy 5% based on clinical nodule size, patient's age, smoking history, should be biopsied and surgical excised. Okay, look at these questions. This word is very vital. The patient noted that more of the symptoms worsened after she takes over-the-counter analgesic. So this patient's presentation is most consistent with aspirin, exacerbated respiratory disease in non-immunologic reaction to aspirin and to other NSAID. Aspirin exacerbated respiratory disease. Aspirin exacerbated respiratory disease. Suspected when Samter triad is present. Samter triad. Can you tell me the Samter triad? C for chronic rhinosinusitis, that means nasal congestion, frontal headache. Can you tell me the Samter triad? Chronic rhinosinusitis, nasal congestion, frontal headache, asthma, intermittent wheezing, chest tiredness, and NSAID-induced respiratory reaction. So aspirin exacerbated respiratory disease involves increased production of pro-inflammatory leukotrienes and decreased production of anti-inflammatory prostaglandin NSAID, shunting toward the leukotriene. Treatment includes avoidance of NSAID. If NSAIDs are absolutely required, desensitization is necessary. So leukotriene pathway inhibitors Xylute or montelukast can be given. Okay, next. Okay, it's CMB can happen, but this patient with hemoptysis chest pain, productive cough, and nodules with a halo sign is more likely aspergillosis. Cytomegalovirus can cause pneumonitis, marked by dyspnea, non-productive cough, low-grade fever, patchy or ground glass opacity on the CT scan. But these patients with hemoptysis, chest pain, productive cough, and nodules of halo sign is more likely to aspergillosis. Invasive pulmonary aspergillosis is characterized by triad, fever, pleuritic chest pain, hemoptysis. CT scan show reveals a nodules with surrounding ground glass opacity, halo sign, nodules with surrounding ground glass opacity. Diagnostic testing includes serum biomarker for cell wall component galactomannan assay, sputum or stain culture. However, Sensitivity is low. Bronchoscopy, bronchoalveolar lavage, and biopsy are required. If invasive, if non-invasive test sensitivity, if non-invasive, if among the lower respiratory culture, ball has the highest predictive value in which patients who has hematologic malignancy and hematologic transplant recipient. Patients with treated 1 to 2 weeks of IV voriconazole plus echinocandin. So IV voriconazole, echinocandin, then transition to oral voriconazole alone. Mortality rate is 50%. Okay, now let's take a break.